Sir, sir,
Yes, tell me.
sir, can we start, sir?
Audience has joined?
Yes, sir. Doctors have started joining, sir.
Okay.
Can we wait for another 5 minutes, sir?
Yeah, we can wait.
Okay.
Hello. Hello. Hello.
Hello.
Hello.
Hello. Yes.
Hello, Mr. Jyoti.
I am Ramurthy here.
Can you hear me?
Yeah, I can hear you.
Can we go live?
Yeah. Doctor is also there. I
Okay,
think
all right.
audience have started joining.
Yeah, right. Over to you.
Thank you. Sir, can we start, sir?
Yeah, we can start.
Okay, sir. Thank you, sir. Good evening, doctor. Myself, Ramurthy, DGM calling from Mankind Curis division. Is a new division, specialty division. We have started 2000, um, last pandemic, sir. Almost 15, 18 months we have got over. And as a Mankind, the first time we have a specialty division. And sir, today's session is very interesting topic we have for all of you. And today our eminent speaker is Dr. P.G. Sundararaman. And before I welcome Dr. P.G. Sundararaman. And good evening, sir. I welcome you for this program. And before starting, sir, I want to give the introduction about our doctor. PG Sundaraman. Definitely, many of our doctors are knowing Dr. PG Sundaraman, but still, Dr. PG Sundaraman sir has completed MBBS 1980 MMC Chennai, and sir has completed MD 1983 from MMC Chennai, and then sir has done a DM endocrinology in 1988 AIMS Delhi, and also a doctor has got 26 years experience in his specialty division, and sir has been well awarded the best doctor by the Tamil Nadu MGR Medical University in Chennai 2012, and also post president of Endocrine Society of Tamil Nadu 2015 and 16. And doctor is also a member of Endocrine Society of India as well as API Endocrine Society of Tamil Nadu. And doctor is currently practicing in Bildroth Hospital, which is in Aryapuram, Chennai. And this is a doctor as today we have one interesting topic on dapagliflozin, the current persistent perspectives and the future outlook. So of course, today the well-known molecule, today in the market, many companies have launched the dapagliflozin, but our dapagliflozin is Justoza is our brand name. It's available as Justoza 10 milligram, 5 milligram, and we look forward your prescription support for our Justoza. And so now the topic is over to our Dr. PG Sundaraman, and about the insight about the dapagliflozin will help us to go a long way. And also, sir, many of your doctors have some queries also can be given in the chat box so that we can answer all your queries after once the session is over, and doctor also will take your queries on the spot itself also. Thank you, sir. Over to Dr. PG Sundaraman. Thank you very much, sir.
Distinguished doctors and friends, at the outset, I wish to thank Mankind Pharma for giving me this opportunity to speak on this topic. In fact, it's quite interesting that during this pandemic era, we have been digitalized. So we changed from real world to digital life. Two important things happened. The people were browsing the computer a lot. And this browsing has got an advantage, and also it sometimes annoys us when the patient asks unnecessary questions and he is going to have a self-diagnosis of the condition. The next important scenario is that when we have a digital experience, this has a lot of advantage of having the conference or the consultation at the ease of our house. So it became simple, and in the bargain, the people did not go out, and this resulted in sedentary habits. And also, this also increased the intake of food. Now, you know very well that diabetes is an important situation, and the three important areas that we must concentrate are the precipitating event, the sugar, salt, and stress. And when these are increased, there is more evident metabolic disorder. And to correct this disorder, we need a medicine and that is going to be the dapagliflozin. And we are going to talk about the current perspectives and the future outlook. Now, why we are bothered about this? Because we in the Southeast Asia has got a very huge number of diabetic population, which is projected to be 140.2 million by 2040. And also India stands second to China, and it is going to overtake it, and it may be quite alarmingly high in India in the future years. In fact, the COVID era has definitely increased the occurrences. This was an interesting study which was published in this year, where in the total amount of hospitalization in the United States, which occurred up to November 18, 2020, 30% were attributable to obesity, 26% to hypertension, and 21% to diabetes, and 12% to heart failure. This was the significant morbidity which resulted in a mortality. So diabetes, hypertension, and heart failure and obesity are important preludes which is going to cause an insult to the metabolic milieu of the humankind. So in India, the important precipitating events are: one, genetic and environment. And basically, we are hunters and gatherers. So we are a population where we must eat less, work more. So, but the scenery changed. In fact, when we became more domesticated, we had a high prevalence of fast foods and sedentary habits. And this had an influence on the epigenetic mechanism. And the factors which increases the metabolic insult is like the nutrition, behavior, stress, the physical activity, working habits, smoking, and alcohol consumption. So genetics and epigenetic mechanisms are the two important precipitating events which is going to increase the diabetes and the metabolic problems. As Indians, as Asian Indians, we have got the prevalence of higher fasting insulin and a higher triglyceride. This is because the insulin sensitivity is less or poor. And this leads on to increase visceral fat. Now, this visceral fat is more prone for insulin resistance and inflammation. So we are having a proneness to a metabolic problem. And along with this, the beta cell mass has been going on impairing in a diabetic population. And this is due to our genetic drift, by meaning that we were basically the people who are descendants from the hunters and gatherers. When we had a lot of food and less to work, this resulted in more number of diabetic population. So the projected incidence or the prevalence is going to be higher in India. So we must be aware about this problem, and we must treat it at the earliest stage. Now, initially, diabetes was more of glucose-centric. So people wanted to reduce hyperglycemia. Then they found that it is beyond glycemic, that is vasculocentric. So we have got traditional complications which are microvascular or macrovascular, as we know very well of. There are also non-traditional concordant comorbidities, like we have got liver disease and cancers, which has a great association with type 2 diabetes mellitus. And there are emerging discordant comorbidities such as depression, asthma, and sleep disturbances. So it is not only hyperglycemia that is going to have an increased morbidity and mortality, but it is also beyond the glycemic parameters, which is going to be a vascular phenomenon. So we need a medicine which is not only tackling the glucose part, but also is able to tackle the vascular part of the metabolic problem. So my plan of presentation today will be how the renal glucose is handled in diabetic population, and how does the SGLT2 inhibitor works, and if so it works, what are the evidences that is going to speak that it has got a vascular benefit, like the various studies which has been highlighted, and how it scores over other molecules, and how the ADA guidelines has changed, and also how we can arrive at a consensus where this molecule is able to reach a larger population. And finally, the side effects of the SGLT2 inhibitors. Now, you are very well aware that the filtered load of glucose, when it passes through the tubules, it is reabsorbed by two important glucose sodium link transporters such as SGLT2 and SGLT1. So this is the amount of reabsorption that occurs. And normally all the glucose in a normal individual is going to be reabsorbed. Now, when we have got hyperglycemia, when there is an intravascular increase in the glucose, the filtered glucose is more, so that it is going to be excreted through the tubules, and this is going to have the urine glucose being positive. So by using this phenomena, when we are blocking this SGL2 by a medicine called dapagliflozin, the glucose, even though it is of a normal range or it is going to be of a higher range, that is going to be excreted without much of reabsorption by the SGLT2. So that is the SGLT2 inhibitor or dapagliflozin. Now, why I am stating this? Because the SGLT2 receptors are upregulated in diabetic population. That is why sometimes even with higher blood glucose level, you don't find the urine glucose being positive. So this set right so that it inhibits the SGLT receptor, and henceforth there is excretion of glucose. When there is excretion of glucose, there is also excretion of sodium, and with the sodium there is also decrease in the glucose level in the intravascular compartment, and that is leading on to a normalization of glucose. So SGL2 inhibitor is a renal, it acts through the renal handling, and henceforth what happens is it is able to reduce the glucolipotoxicity. So once you reduce the glucolipotoxicity, that actually reduces the resistance and it increases the insulin sensitivity. So it is independent of the action of an secretagogue. So it doesn't act on the pancreas, but since it excretes the glucose via the tubules, it is going to decrease the glucolipotoxicity. So there is a better glucose utilization by the peripheral tissue. But it has got other effect that it increases the glucagon, and in that way, it may increase the endogenous glucose production. This is very important so that hypoglycemia is not going to be prevalent. So hypoglycemia is not present. So it is able to excrete the glucose, but also it is not going to cause hypoglycemia. So as I told you that in spite of so many medicines that we had like metformin, sulfonylureas, thiazolidinones or DPP4 inhibitors, insulin, still the heart failure and the CKD events are rising. And in fact, it is very interesting that 12 to 45% patients with heart failure have type 2 diabetes, and 8.9% of the Indian population has got diabetes, and 32% of patients with the coronary artery disease have type 2 diabetes. So it is very relevant here that we need a molecule which is going to not only target the glycemic level, but it must target beyond glycemic parameters. So in India, diabetes appears to be more coronary vascular event and renal risk than hyperglycemia risk. Hence, we are looking to a medicine that is going to manage this dual problem. Now, why was the CVOT, the outcome trial, was mandated by FDA is to, when we know that it all precipitated when rosiglitazone increased the risk of heart attack and heart-related deaths. So we must define what is the major adverse cardiovascular events that is going to occur with a molecule. So that is the primary endpoint. So that became a prerequisite for any medicine that is going to be introduced into the market for the managing the diabetes mellitus. So declaritimi is a randomly assigned in patients with the type 2 diabetes who had or were at risk of atherosclerotic cardiovascular disease. In fact, it was numbering around 17,160 patients. And the primary efficacy outcome were the MACE. And the secondary efficacy outcome was a renal composite endpoints and death due to any cause. Now, if you see this picture, you will know that even though the MACE was not much of an improvement, there was a lot of improvement in the form of hospitalization of heart failure was lesser, ischemic stroke was lesser, and death from cardiovascular or non-cardiovascular cause was less when dapagliflozin was used compared with the placebo. So the hazard ratio definitely has an edge of a significant benefit of a lower incidence of heart failure, hospitalization, and death due to the cardiovascular cause. So this is the largest trial which showed a consistent, regardless of the atherosclerotic cardiovascular disease which are present or not, or a heart failure which is present or not, definitely had a better benefit in preventing the heart failure hospitalization and also in the cardiac related deaths. Now, this is the CVD real study, which is to compare the DPP4 and also the other oral anti-diabetic agents, and the major CEV events in a real world setting. So this was a real world setting where they compared the dapagliflozin with other OADs and also with the DPP4 inhibitors. It definitely showed a lower all-cause deaths, heart failure, and it also had lower CV events, atrial fibrillation, and death and failure. So it is definitely superior over other oral anti-diabetic medication in the form of CV risk aversions, whether it is going to be a death or a heart failure or a heart failure or death. So we have seen that compared with a placebo, it would definitely edge on the heart failure hospitalization and cardiovascular death. And when it was compared with the other oral anti-diabetic medication and also with DPP4 inhibitor, it has got a better role, preventive role in the form of cardiovascular events, in the form of failure, atrial fibrillation, or cardiac related death with this study. And this was quite relevant because dapagliflozin had the highest on-treatment exposure time in all countries included in this analysis. Now, if you go through this risk reduction ratio and the hazards ratio, compared with the other OADs, definitely it has a better effects on the prevention of all-cause death, myocardial infarction, hospital failure patients, and prevented the admissions due to heart failure and also stroke. This is an elegant study where it was shown whether dapagliflozin is useful in a diabetic or in a non-diabetic population, which was a phase 3 placebo-controlled study where patients were selected with evidence of cardiac failure from 2 to 4, with ejection fraction less than 40 and the pro-BNP being higher. They compared with a placebo and also using the dapagliflozin 10 milligrams once daily. And this has definitely caused the primary composite outcome, like in the form of CV death or heart failure hospitalization or urgent heart failure visits. If you see that between the diabetes and the non-diabetes, dapagliflozin has shown 27% of heart failure risk reduction in non-diabetic patients. So a question arises whether SGLT2 inhibitor is a medicine for diabetes or for a heart failure. So because here is a unity where we know that diabetes mellitus will cause increased vascular insult, because we know that there are various mechanisms like the advanced glycosylation end products or various other causes which is going to cause the vascular problem, endothelial problem. And this was not only for diabetes, but also in cases where they are not a diabetic due to hypertension or any other cause, where it has been found, irrespective of diabetes, dapagliflozin has got a good effect on the risk reduction, especially for the heart failure. Now, what happens to the kidneys? Now, they have shown with the DAPA-CKD about 4,304 patients with CKD, atherosclerosis, with the independent of heart failure. They have got a very good cardiorenal outcome. So in patients with CKD, with or without type 2 diabetes mellitus, dapagliflozin compared reduce the risk of kidney failure, reduce the risk of death of CV causes of hospitalization for heart failure. They had a prolonged survival. So in end nutshell, dapagliflozin is a useful molecule for being a vasculocentric drug, where it has got an effect on the heart and the kidneys. So cardiorenal outcome has been very well stabilized with this DAPA CKD trial, where they found that the primary endpoints and the secondary endpoints compared with the dapagliflozin, you find that if the events are lesser, whether it is going to be a primary endpoint or a secondary endpoint. So dapagliflozin has got a definite benefit which can be extended to patients with a broad range of underlying causes of chronic kidney disease other than diabetic nephropathy, including those with primary glomerulonephritis and ischemic or hypertensive kidney disease. So it is a molecule that is being shared by diabetologists, endocrinologists, physician, cardiologists, nephrologists. So it's a molecule which is a common molecule, so which has been quite useful in not only reducing the hyperglycemia, but also it is a useful molecule which will decrease the load intravascularly, and it also has got a benefit on the cardiorenal outcomes. So finally, what we mean by this is that in a cardiac angle, it reduces the myocardial stretch. So the arrhythmia is less. It improves diastolic and systolic function. It increases the natriuresis and osmotic diuresis, which can reduce the blood pressure. There is reduction of sympathetic tone, reduction in interstitial fluid. This is very important compared with the diuretic. SGL2 inhibitor decrease the interstitial fluid. So this is also will add on to the reduction in the failure rate. It corrects the nocturnal dip in hypertensive patients. It reduces inflammation and oxidative stress. And since the glucose is lacking intravascularly, the energy is used from the ketones. So the cardiac muscle is able to use the ketones. So ischemic preconditioning is better. In the renal angle, it reduces the intraglomerular pressure. And it also inhibits neprilysin, which are distinctly very, very significant in reducing diabetic nephropathy. Reduction in the albuminuria, it increases the renal perfusion so that renal hypoxemia is reduced. There is decrease in the afterload because of the afferent arteriole, the efferent arterial modification, and very important is the sodium hydrogen exchange mechanism. This sodium hydrogen exchange mechanism is also present in the cardiac and also in the renal parameters. So all this will result in glycosuria, natriuresis, decrease the blood pressure, and since there is a decrease in the fluid, sodium, glucose, energy, there is a decrease in the weight. So it has got a multitude of benefit which is apart from the glycemic status. So as an Asian Indian, we know that we have got higher insulin resistance, higher CRP levels, we are thin fat Indians, and we are more susceptible to type 2 diabetes and the coronary artery disease. And this results in obesity, hyperglycemia, hypertension. So now we must know whether this molecule has got a consistent effect, whether it is going to reduce the HbA1c for a prolonged period. So this was compared with other molecules, and when it was used as a monotherapy or add-on to metformin or add-on to sulfonylurea, or it can be add-on to insulin. So it can be used with other therapy or oral anti-diabetic medicine or insulin. And it's quite interesting here if you see this cartoon where they have compared placebo plus metformin plus sulfonylurea, where the baseline HbA1c is 8.2, and when they compared with the DAPA, MET, and SU, they found a significant drop of the HbA1c compared with the DAPA and the placebo. It was 0.86 when the molecules are combined with dapagliflozin compared to the molecules combined with the placebo, which is only 0.17. So dapagliflozin works in patients who are not controlled on sulfonylurea and metformin. So when you add on to a molecule, there is a consistent effect in the reduction of the HbA1c, and also there is a better reduction of HbA1c, which is around 0.86. Now, reduction in HbA1c was sustained over time. So if you see this graph, there we see that they have followed up the study for 102 weeks. And in one set of population, they had placebo plus metformin, and in other set of population with a dapagliflozin plus metformin, which is around the equal numbers. And when you adjust this for HbA1c, you find that the maintenance of HbA1c was consistently prevalent in the diabetic population who had dapagliflozin added to metformin, which was quite significantly seen even after 102 weeks, which is around 0.80% difference. So we have a definite advantage when you combine this dapagliflozin with other oral anti-diabetic medicine or insulin. The HbA1c reduction is quite significant, and the HbA1c reduction is sustained when you combine along with a metformin compared with a placebo plus metformin arm. So this is also another study where it has shown a consistent reduction of HbA1c of more than 104 weeks. So it's a quite large study where they had a dapagliflozin plus metformin arm and a glycoside plus metformin arm. So when you compare this, even though the glycoside plus metformin had an initial drop in the glycemic parameters in HbA1c, when you project this graph, when they are followed up for a longer period of time, you find the confidence interval and the risk reduction was better when the dapagliflozin was combined with metformin compared with the glycoside plus metformin. So this is also another study where they combined dapagliflozin with insulin and they had an overall benefit. And it also decreased the insulin doses. And these were in type 2 diabetic population. Now, that was regarding the glycemic status. Here, when it was studied in the hypertensive patients where the systolic and the diastolic blood pressure around 3 to 4 millimeters was reduced, and this was compared to the control group, and here you see that the systolic blood pressure around 4.4 and a diastolic blood pressure of 2.1 reduction was seen. And it had a very good effect on the weight loss. So this, along with the vascular benefit, it also decreases the weight. So you know very well that diabetes is an important problem where a combination of diabetes plus obesity is going to increase the morbidity and mortality and more endothelial dysfunction. So here is a molecule where it not only targets the glucose, but it also has got a benefit of a weight loss. Here they had two arms, one arm with a glyphosate plus metformin, which was numbering around 401 patients, and a mean baseline weight of 87.6 kgs, and another arm, dapagliflozin with metformin, where the baseline weight was 88.4 kgs. But what they found is quite interesting. The arm that had a glyphosate plus metformin, there was a weight gain of 1.36 kgs. Whereas the arm with the dapagliflozin plus metformin, there is a weight loss of 3.70 kgs. So it has got a definite benefit on the weight. And as I told you, since it increases the glucagon level, the endogenous glucose production is going to be maintained. So the events of hypoglycemia is lesser when dapagliflozin is used compared with a sulfonylurea or a secretagogue. And this graph definitely shows that it is statistically significant when dapagliflozin plus metformin versus a glyphosate plus metformin. Around 52 weeks, they found the incidence of hypoglycemia was 40.8% in the glyphosate arm compared to the dapagliflozin arm. So this all have created the ADA to revise the guidelines because they found that the condition which is going to have an increased morbidity and mortality is not hyperglycemia, but it is beyond hyperglycemia. So if there is beyond hyperglycemia, the important parameters are the cardiovascular death or a stroke or a renal problem. So the preference or the initial therapy depends upon what insult the patient or a diabetic patient is having, whether he is suffering from an atherosclerotic cardiovascular disease or a heart failure or a chronic kidney disease with persistent albuminuria. Then the first drug to target or to start with will be an SGLT2 inhibitor, which can be added on with the other oral anti-diabetic medication depending upon the particular scenario of that particular patient. Good. This only gives a rough comparison of the various therapy that we have. Is that the efficacy, the hypos, the weight, the cost, and the CV safety. Now, if you see that the SGLT2 inhibitors, when it was introduced into the market, it was exorbitantly costly. So whenever a drug is very costly, and even though it has got a very good benefit, not only on the glucose-centric, but also as a vascular-centric, it cannot reach to the maximum number of people who are suffering with diabetes. So the only way is to reduce the cost of a medication. So this was an interesting article which was published in the recent month, 2021, where they found out because the pharmaceutical company has introduced SGL2 inhibitors at a lower cost, there has been an expanding access to the newer medicine. So it is going to be really available for a lower middle income group. So this is because of the cost effectiveness, because of the price. So when you have an effective drug which is able to reach the population, and you know very well that it is having an effect on the glycemic status and also effect on the vascular parameters, definitely the projection of heart failure hospitalization, cardiovascular death events, or renal events will definitely come down. You know very well when the ACE inhibitors and ARB was introduced, definitely it had got a very good effect on the albuminuria and other complications. So here we have got a molecule which has got a drastic advantage on these parameters, and when this is available to the maximum number of patients, definitely it will decrease the burden of not only for the patient but also in the GDP of the country. So dapagliflozin should be added in the diabetes treatment armamentarium to reduce the lifetime risk. Should be the second line drug after metformin patient established risk factors. It is an add-on therapy to other OAD and insulin. Patient with or without diabetes who are having heart failure or other CVDs, it can be used. And especially when in case of CKD, if patient without diabetes with a reduced EGFR can also be applicable. And dapagliflozin has the ability to reduce HbA1c, weight, blood pressure, and many other desirable effects. Good. Now, any molecule will have what side effects? The important problem with the gliflozin is genitourinary infection. So that must be definitely addressed. So hygiene, genital hygiene is important. So the 3H to prevent genital infections are adequate hydration, hygiene, especially genital hygiene, and we must inform the healthcare professional so that they report to us. And the cause, another important problem is the euglycemic ketoacidosis. The gliflozin molecule must not be used in a catabolic situation, in an infectious condition, or in a case of an insulinopenic patient. Then in these conditions, definitely they may go into euglycemic ketoacidosis or in fasting when there is starvation. So catabolic state, starvation, infection, insulinopenic, these are conditions we must not use the gliflozin. Another important problem they have arised is the bone mineral density. They have not shown much evidences in the recent studies. Another important problem is the cancer, and these are all very few studies which has highlighted it, but in the real world setting, it is not being very well shown. So the take-home message for this is there's a huge prevalence and unique clinical profile management of diabetes in India, so that it is less satisfactory. This is because we have got early onset of diabetes, and the Asian Indians have a longer life with diabetes because the diabetes sets in very early. So if it occurs early, the vascular complications is also more. So dapagliflozin offers not only glycemic control, it has an effect on the weight loss, additional cardiorenal protection, and it also takes care about the glycemic variability and time in range when combined with the other oral anti-diabetic medication. The hypoglycemia is less prevalent. is an additive effect as when used with the other antihypertensives. It is also useful in the fatty liver, and we need further studies of further the horizons of the usefulness of dapagliflozin or other gliflozin, whether it is going to change the picture of the metabolic insult in the diabetic population. So I want to end my talk. தீயளவு அன்றி தெரியான் பெரிது உண்ணின் நோயளவு இன்றி படும். That is, whatever the medication is there, you must eat to what you need. You must not overeat. So lifestyle modification is there, and above the lifestyle modification, then we need some medication. And amongst this medication, we need a medicine which not only controls the glycemic status, but also takes care about beyond the glycemic situation, whether it is going to be a vascular phenomena or in the form of weight or in the form of blood pressure or a cardiovascular effects or a renal problem. So with that, I want to thank you for your patient listening. Thank you very much.
Sir, yes, sir. Thank you very much, sir. A lot of insights on all the parameters. The only drug, as you rightly told, sir, the first drug, sir, after statin, launched in diabetic indication. Over a period of time, it is the now extends origin regarding the cardiology, even nephrology, nephro segment, and you have nicely given the points. Definitely be very useful, sir. On behalf of our doctor, sir, we have selected two questions. May I ask, sir?
Yeah, please.
Thank you, sir. Sir, one thing, sir, with the DAPA is launched in the segment of diabetology, diabetic drug. Now the new indication have been extended on non-diabetic patient also, sir. Can you throw some light on non-diabetic population? Which type of population non-diabetic we can use DAPA, sir?
Yeah, it has been, as I told you in my slides, that the DAPA-HF and the DAPA-CKD has definitely shown insight into the usage of this molecule, even in non-diabetic population. So that is why now a lot of cardiologists is using this medication because it is not going to have an effect on the pancreas. It is not a secretagogue. It has nothing to do with the pancreas. So it is more of a vasculocentric, more of a renal oriented medication. So it has got a definitive. That's why my last slide, where future study, it may involve not only cardiology, but the nephrology, but it may also involve other field of our medicine. So that becomes, see, in fact, there are conditions, well, if you take a polycystic ovarian disease, where, or in a case of obesity, and obesity, there are now a molecule, which is the gliflozin molecule, is also used for obesity in 300 micrograms. So the scenario will expand. So till now, we know that it can be used even in a non-diabetic population with evidence of heart failure, poor ejection fraction, or CKD.
Thank you, sir. And in the slide also, sir, I just gone through your slide during your presentation, sir. Even the non-diabetic population that delay the incidence of diabetes for further more period with DAPA. Yeah. That also you've added, sir. Thank you very much, sir. And one more question is, where do you place our GLT2 inhibitors like DAPA in the treatment of diabetes, sir?
Yeah, that ADA guidelines have definitely highlighted that when there's evidence of atherosclerotic cardiovascular disease, when there is evidence of albuminuria, when there is evidence of CKD, definitely it has got a role to play where you can combine a metformin with SGLT2 inhibitor to start with.
Very much, sir. I thank on behalf of our Curious Mankind specialties to Dr. Sir. for all your insights and future outlook on DAPA as a molecule and our brand Justoza. And as you know pretty well, sir, we have shared during our field work with all the doctors, sir, the first in Indian first company to launch Justoza in API DMF grade. It's a quality grade approved by US FDA. DMF is drug master file grade, sir. So for the internationally accepted quality standard, whatever it is exported to US or Europe, the first company to provide the API DMF grade in our brand Justoza with very affordable pricing, sir. And thank you very much, sir. Thanks for all. Thank you to all the doctors to spare the very valuable time of yours. And thank you once again to our Dr. P. Sundaraman, sir. Very kind of you, sir. And thanks to one and all.
Thank you very much. Good night.
Very kind of, sir. Thank you, sir.
Exact